My name is Seng here. I'm a pharmacist, so I'm taking you to the pharmacological interventions of bipolar disorder. Just bear with me because this is a bit heavy duty, so I've actually done it by presenting it in tables form itself. The details will be inside the booklet, okay, bipolar booklet that's available to you. Okay, the overview of my presentation, I'll be talking about the acute treatment of bipolar, mania, bipolar depression, rapid cycling and mixed states, electroconvulsive therapy. Okay, followed by maintenance treatment of relapse prevention, treatment discontinuation and rapid cycling, and substance misuse in bipolar disorders. Okay, of every category itself, I will be talking about the treatment roles of different pharmacological classes of medications. Looking at acute bipolar mania, okay, I've actually divided it very nicely for you to have a look. On the left-hand side is the beneficial efficacy from clinical trials, and the right-hand side is the lacking or controversial efficacy. For beneficial efficacy of bipolar treatment of bipolar mania, antipsychotics such as the typicals like haloperidol, aripiprazole, olanzapine, quetiapine, risperidone, ziprasidone itself can be used to treat bipolar mania. Lithium, mood stabilizers like sodium valproate and carbamazepine, and perhaps benzodiazepines itself in terms of clonazepam has been shown in randomized controlled trials to reduce manic symptoms. Over here, I will have lacking of and controversial efficacy of lamotrigine, gabapentin, and topiramate. Okay, having not enough lacking efficacy or even not clinically significant to treat bipolar mania. Lorazepam, I put in the last row here, is actually a potential but not definitive efficacy in treatment of bipolar mania. Okay, continuing the benzodiazepines, right, the one on the right-hand side, okay, one has to bear in mind the long-term risk of psychological and physical dependence, tolerance and withdrawal symptoms. And last, if for inadequate response to mood stabilizer monotherapy, one can actually try a combination therapy of either antipsychotic and mood stabilizer. For acute agitation and aggression, beneficial efficacies that have been shown to be beneficial to treat acute agitation would be antipsychotics, haloperidol, either the IM or the oral form, olanzapine, same oral or the IM form, oral quetiapine, or even the intramuscular form of aripiprazole. Benzodiazepines like clonazepam and lorazepam, either intramuscular or orals, can also be used. There's actually lacking of a controversial efficacy with the use of clopixyl Acufase, as you can see on the right-hand side. Okay, now for acute bipolar depression, we've covered mania, we've covered acute agitation. Now we'll move on to depression. Okay, what has worked so far in clinical trials for beneficial efficacies will be under antipsychotics like quetiapine, olanzapine and fluoxetine combination, lithium and lamotrigine combination. Okay, the ones that have been lacking and controversial efficacy will be sodium valproate and carbamazepine. Lamotrigine itself has been there's still lack of evidence to say conclusively that it can be used to treat acute bipolar depression on its own, monotherapy. And of course, apart on the antidepressants, right? Antidepressants have actually been shown to have limited efficacy as first-line treatment for bipolar depression. Okay, they are actually been shown to only be effective in the short-term treatment for up to 8 weeks. And usually, antidepressants are added to existing optimal mood stabilizer for persistent depression. And of course, the lowest treatment dose and the shortest duration, okay, would actually be recommended as good practice points. Now over to rapid cycling and mixed states. Under beneficial efficacy, what has worked shown to work in clinical trials, first line will be either using sodium valproate or use quetiapine. Plus minus means you can either add on, combine with a lithium or not. And second line, lithium together with lamotrigine. For antidepressants, they have been found to be no benefit to continue after the remission of a rapid cycling or mixed state. Non-pharmacological treatments like RTMS, repetitive transcranial magnetic stimulation itself, also has not shown to work. Mixed states, mood stabilizers, sodium valproate and carbamazepine have been shown to be beneficial. And lithium still has lacking and all controversial efficacy in treatment of mixed states. Now over to ECT or electroconvulsive therapy. ECT has been found to aid in remission and marked symptom reduction improvement in bipolar depression, either mania and depression. It's recommended in mania or depression episodes itself, or even mixed states in circumstances where it's actually severe intensity, failure to respond to, or even unfeasible pharmacotherapy. Okay, now over to maintenance treatment. What has worked so far for beneficial efficacy? Olanzapine, lithium, sodium valproate, lamotrigine, if it's actually initially stabilized on it. For olanzapine, lithium, and sodium valproate, either pole of treatment, either is the depression maintenance or even the manic mania maintenance. Aripiprazole has been shown to be able to work for recent manic or mixed episodes. Quetiapine with combination with lithium or sodium valproate for bipolar 1 disorder. And for the rapid cyclists, lithium or sodium valproate for maintenance. Okay, just a note about antidepressants in the long-term use for bipolar depression maintenance. Okay, that's been shown from the STAT-BD trial, okay, that there's actually no significant clinical benefit post 8 weeks after the remission of bipolar depression episode. The usage of antidepressants may be gradually discontinued at least 8 weeks post-depressive remission to minimize the risk of having a new depressive episode. Increased risk of mania or hypomanic switch, okay, when using antidepressants without a mood stabilizer has been shown. Okay, that in bipolar 2 disorder, there's also no benefit in using antidepressants. And of course, newer ones, antidepressants like SSRIs, can actually delay the onset of subsequent depressive episodes without the risk of manic switch. Now moving on to medication discontinuation of the bipolar medications. Right, there's actually been shown to have an increased relapse risk with discontinuation of maintenance medications. And for planned discontinuation, like for example in pregnancy, okay, there should be a gradual dosage tapering over several weeks to minimize relapse or risk of new illness. Okay, and the last part of my portion, substance misuse, there has been shown to be a higher association of bipolar disorder with substance misuse, example, drug or alcohol abuse. And substance abuse in bipolar disorder has been associated with earlier onset and frequency of bipolar episodes, slow remission, rapid cycling and mixed states, increased suicidality, increased emergency room and hospitalizations, poor medication adherence, suboptimal response to lithium. As such, addiction disorders in bipolar disorders should be treated, right, under grade A and level 1's evidence plus in an integrated specialist treatment center under good practice points. Right, thank you very much. I hand the mic over to Zhen.